Hello, this is Stephen Holloway again. This is Nursing 203, Module A, Congenital Heart Defects. We're doing our last segment on congenital heart defects. This time we're going to be talking about aortic stenosis. Aortic stenosis is one of those congenital heart defects that has obstruction of the left ventricular outflow. As we look at aortic stenosis, the instance is approximately 3 to 6% of the congenital heart defects. It can occur singularly, and it also can occur with other types of defects. It does tend to run more in males than females, 4 times more prevalent in males than in females. And really what we're looking at, and when we look at the structure of the heart, the aortic valve, the valve coming from the left ventricle going into the aorta, is stenosed or strictured. For some reason the valve leaflets are not opening correctly. There's some problem there, and so the blood has a very difficult time leaving the left ventricle and going into the aorta. Because of this, there is a decreased amount of blood leaving that left ventricle going into the aorta, and that basically prevents the nutrition and the nutrition and oxygen from getting to the central circulation. This also causes a backup of pressure in the blood in the left ventricle, and then causes a backup into the lungs. So we can see signs of congestive heart failure from this process. If it goes on long enough, we can see left ventricular hypertrophy, and that's due to the heart having to work so hard to push the blood past that stenotic area. Typically, the left ventricles will fail. We get increased pressure in the left atrium, and then increased pressures in the pulmonary veins and develop pulmonary edema. That's the worst scenario that we can see with this. So what are some of the clinical manifestations that we see? For the majority of children, it's benign until they get a little bit older, usually not diagnosed in childhood. There is something called critical AS, and we'll talk a little bit more about that. Those children are very, very sick. But the majority of children with aortic stenosis, there's not a problem until they get a little bit older. Once they get a little bit older, they need more cardiac output to meet the demands, and the heart cannot supply that cardiac output. So these children will begin to have signs and symptoms related to that. These children typically they get evaluated because they come in to see their primary care provider, and a murmur is heard. The murmurs are usually a systolic type things, heard best at the second right intercostal space. The murmur may radiate up to the right shoulder, clavicle, and up to the neck. May also be heard at the apex. Sometimes a thrill may be felt at the suprasternal notch because of that stenosis type process. When we look at aortic stenosis, it's measured by the severity is measured by its symptoms and typically by what we call the gradient, and that is the difference in the pressure before the stenotic area, which is the pressure within the left ventricle, and the pressure on the distal side of the stenotic area. So we're looking at this pressure gradient difference across that stenotic area. What we're doing, and that's usually measured by echocardiogram, or it can be measured by cardiac catheterization. But this stenosis basically is going to cause decreased cardiac output. You may have faint pulses in the distal areas, typically because you can't get enough cardiac output out there. You may see a decreased blood pressure, increased heart rate. These patients may complain of syncope. In smaller infants that do become symptomatic, you may see that they can't feed for long periods of time because of the sucking and the activity that goes on with that requires increased cardiac output. Older children, again, where we see it more often because now there's a decrease in that cardiac output. We can't meet the demands of the systemic circulation. These children may get chest pain similar to angina, exertional fatigue, and dyspnea as part of that problem. If we're seeing these type problems developing in the children, we need to go ahead and get them evaluated. If they're very severe, we need to get them their oxygen, and with the exertion, sudden death can occur as a part of this. Diagnostic, typically we're looking at an echocardiogram with these children, and it's through that echocardiogram that we can see the stenotic areas, and then we can kind of measure that gradient, that difference between the left ventricle pressure and the pressure in the aorta afterwards. So we're looking at those gradients. Get my page turned, I apologize. A gradient less than 25 is considered to be mild, but really what we're looking at is you get above 25, typically you're going to start seeing symptomology with these children. What are we going to do? And it's going to depend on what's going on with the child, is what's happening. And we'll talk a little bit more about the really sick child in a moment. But typically these children are older, so they're going to come in, they're having these symptoms, they're sent for evaluation, and then the diagnosis of aortic stenosis is made. What happens is these children then will go in for a cardiac catheterization, and as part of that catheterization, they'll do a balloon valvoplasty on the aortic valve. The balloon is blown up over the valve or inside the valve and breaks loose those stenotic areas in the valve. Now, when this occurs, the children typically will have a complication of aortic regurgitation for the rest of their lives, because once you break that stenosis, the valve never goes back together correctly. If they're unable to break up the stenosis, or the regurgitation is too much with these children, many times they'll have to go in for valve replacement surgery. Now, that is an open heart procedure. These children will be placed on coronary bypass machines, and they will come back being very, very ill back to the critical care units. Typically, these children have a mechanical valve put in place. These mechanical valves then require Coumadin to be given for the remainder of their life to help prevent blood clots over those areas. So these children typically are going to may end up with a valve replacement at some place in their lifetime. I had a cousin who basically was 28 before his was found, and was, as part of a routine physical exam, it was noted he ended up having to have a valve replacement at age 28, and has done well. Had a mechanical valve put in, is on the Coumadin. The thing with the mechanical valves is typically they last a lifetime. They're actually using some different types of valves, but they may, and you don't have to take Coumadin, but they may have to be replaced within 10 to 15 years. So if we're looking at a young child, big decisions to be making, and if, look back at the complications that can go along with Coumadin with that process as well. Now, there are children that present with what's called critical aortic stenosis. These are very critically ill infants that present with this. These children are in severe distress. They're having multiple type problems, and the goal is to try to stabilize these children until surgery can be done to open up that valve for them, actually do a valve replacement for these children. Typically, the first thing that we're going to try to do is, most of the time these are newborn type infants, we're going to actually give them prostaglandins. Remember, the prostaglandins are given to keep that ductus arterius open. That ductus arterius actually allows more blood to get out into the systemic circulation so that we can get that blood flow going to the areas. They may be put on beta blockers trying to decrease that heart rate and help decrease that cardiac hypertrophy that can go on. Once we get them stabilized, then they may try balloon valvoplasty on them, but typically if they're that critical, they'll probably go ahead and do a valve surgery on them. They may try to go in and actually surgically dilate or divide the stenotic valve. If they get in there and it's not, and they can't do that, they may have to do a valve replacement surgery. These children are typically going to be put on prophylactic antibiotics to prevent the development of endocarditis. But these children are basically with critical aortic stenosis or a medical emergency. They need to have care immediately. And again, these are children that you're going to see typically present with this right after birth. Complications, we kind of talked about complications of the valvoplasty or the aortic regurgitation. You can get dysrhythmias from that, can develop heart blocks and bleeding. Typically the heart blocks and the arrhythmias will go away. It's a temporary type process. And of course the bleeding has to do with the procedure itself. Outcomes, typically if it's going to depend on how severe the stenosis was and what goes on. Again, we talked about with the valvoplasty, these children may have to go back for more surgery because of the regurgitation. But if the child goes untreated, again, here in the U.S., that's not typically what's going to happen, but in third world countries, you may see that. It's going to depend on the severity of the stenosis. If that gradient is greater than 50, the chances of survival are not very good. These children are going to need a lot of care, and so if the gradient is greater than 50, the survivability without surgery is minimal. Aortic stenosis is just another one of the congenital heart defects. Remember, the big problem is the valve is stenotic. It's hard to get blood past that stenotic area. So you have all the developments of congestive heart failure because of the backup, and you have the problems with getting nutrition and oxygen to the systemic circulation. Most of the time, in most children, it's not diagnosed until around school age when they're going in for their physicals for school and maybe hear a murmur at that time. There is a small number of children that will be born with critical aortic stenosis or develop that right after birth. That is a medical emergency, and we have to stabilize those children. But most of the time, these children do well after surgery. If they have to have a valve replacement, remember they go on Coumadin, and with the Coumadin, the risks that go along with that. That is the conclusion of the aortic stenosis and the conclusion of the congenital heart defects. Good luck on your exams.